everyone. My name's Dr. Sally Coggins, and I am here today to present to you some updates in FIP treatment, and I'm finding it increasingly difficult to fit this kind of presentation into a 50-minute webinar, but I'm going to assume a reasonable level of existing knowledge given the audience for this webinar. So I am a feline veterinarian. I have recently completed a PhD in FIP treatment, and I'm about to commence a postdoctoral research fellowship position at the University of Sydney in Australia to continue my research in FIP. Firstly, my disclosures. I've delivered many webinars with and without honoraria on the topic of FIP diagnosis. These are my current research support people, and no commercial entity has influenced my research or the content of this lecture. I will be discussing off-label and unapproved use of various antiviral compounds, including remdesivir, GS441524, molnupiravir, EIDD1931, and Paxlovid. So the general outline for today's webinar, essentially, I want to sort of start with a little bit of an update on global access, particularly the GS441524. We will go through treatment protocols that are currently being implemented for GS, remdesivir, EIDD1931, and molnupiravir. And I'm then going to go on to discuss the use of the protease inhibitors, so in particular Paxlovid and GC376. And then also some more recent sort of research that's helping to fill in some of those knowledge gaps. I'm going to go through more of a Q&A sort of session at the end with commonly asked questions and where my answers are currently sitting based on the existing research that we have available. But I guess the sort of big take-homes at the moment, particularly if there is anyone tuning into this webinar who's reasonably new to this space of FIP treatment, FIP is a treatable disease. So with prompt treatment using a nucleoside analog, we can expect long-term survival rates of at least 77 to 96%. Of the cats who die, most mortalities are still occurring in that first week of treatment. So in general, if your patient survives that first week of treatment, often their long-term survival statistics will go up even higher. And at the currently recommended dose rates, re-emergent FIP does appear to be quite rare. A lot of the existing literature, particularly our publication from the University of Sydney, a prospective that looked at remdesivir treatment and GS treatment, we utilise much lower dose rates for the first half of recruitment. And so it's important to sort of recognise that re-emergent FIP at current dose rates does seem to have decreased further, but we're still waiting for the next round of publications to support that. So what are we using to treat FIP? And the big players in this space are going to be remdesivir, GS441524, molnupiravir, and EIDD1931. And these drugs are linked. So essentially remdesivir is a prodrug nucleotide, and it gets metabolized into GS441524, which is the core nucleoside analog. Then we have molnupiravir, which is the prodrug nucleotide that is again subsequently hydrolyzed into EIDD1931 in vivo. So we can give remdesivir and get GS, or we can give GS, and similarly we can give molnupiravir and get EIDD1931, or we can just give straight EIDD1931. And I guess just to highlight something in particular with remdesivir and GS441524. So as I mentioned, remdesivir is the prodrug. Essentially, we see hydrolysis of this extra phosphate group, which turns these two molecules into the same thing, if I move my head out of the way. But it is really important to know that this gets further hydrolyzed into the active triphosphate, and it's actually this active triphosphate that is pharmacologically active. This typically is occurring intracellularly. With regards to global availability of remdesivir and GS441524, I guess as a blanket statement, I would say that black market or unlicensed formulations of particularly GS441524 are probably available globally. But in terms of sort of legally accessible, really we're talking about access to compounded formulations of these drugs, and particularly with the GS441524, we've seen significant improvement. when I first started my PhD back at the end of 2020, Australia was the only country to have legal access to compounded formulations of remdesivir. And within 12 months, we got access to GS 441524, and so did the UK. But since then, we've seen continued improvement to this access. So the current list of countries that I'm at least aware of that can access compounded GS or remdesivir include Australia, Canada, Cyprus, the Czech Republic, Finland, France, Germany, Hong Kong, Ireland, Japan, New Zealand, Norway, Portugal, Singapore, South Africa, Sweden, Switzerland, United Kingdom, and the United States. And I guess just to put that on a global map, so the majority of the world in terms of supply of compounded formulations is coming from BOVA Group. So there's BOVA UK and BOVA Australia. BOVA UK are the ones that are doing the international distribution to the countries that have these purple stars. It is important to note that in Australia, there is another compounder in the market now, which is creating some competition, which I always think competition is good. When it comes to Germany and Switzerland, these countries can still only access BOVA for research purposes only. The New Zealanders have had access to parenteral remdesivir and oral remdesivir, so not GS, but actually remdesivir through Optimus Healthcare. And then there's been a recent partnership between Stokes Pharmacy in the USA with BOVA. There is also now SVC Pharmacy and other compounders getting into the game in the US, which again is creating some competition. And Europe, we're starting to see a little bit more improvement, particularly in France. So it is now legal to utilize compounded formulations of GS in France. I believe Delpech Pharmacy are the ones that are apparently doing it at the moment. I know there is likely to be another BOVA collaboration with France and similarly another BOVA collaboration in Canada that will make it easier to sort of more rapidly access GS, particularly in Canada, and hopefully the details of that will be released shortly. And in terms of where we're up to with expected survival for compounded remdesivir and GS, so these are all studies that have utilized the legal compounded formulation, so all used BOVA Group's product. There was our prospective from Australia, which achieved 96% survival. We had another retrospective study that was published out of the UK that achieved 81%. Then there was a big retrospective collaborative publication between the UK and Australia that achieved 84.4%. And then the newest publication is out of the University of Munich, so in Germany, that is looked at short-term versus traditional 84-day courses of treatment, and they achieved an overall survival statistic of 95%. And I will go into the discussion around shorter duration of treatment a little later on in this talk. Expected survival to unlicensed GS does appear to be pretty similar. So this is unpublished data. It's a follow-up study that has utilized owner-reported data by Dr. Sam Evans' group at Colorado State University. And essentially out of the 179 cats with complete outcome data, we're seeing a similar statistic at that 83% considered to be cured. I think just a really important thing to highlight for those of you that are unfortunately still dependent on unlicensed formulations, or your clients are dependent on unlicensed formulations as the only avenue for treatment. There is a huge amount of variability. So this is again courtesy of Dr. Sam Evans from Colorado State University. Their research group analyzed a whole bunch of different formulations that were entering the US of GS and found that of the oral formulations, they were a lot more variable than the injectable. So injectable is still quite variable, but you can end up with anything between 75% more and 58% less. Oh, sorry, on average 39% less of the drug in the tablet than is inferred by the label, and the labeling and dosing directions for these unlicensed formulations are quite confusing as well. For any of you that, particularly in countries like the US, where you've gone from having clients that are dependent on black market sources to now having an avenue to legally write a prescription for compounded formulations, we just say pick up as if you're almost starting again. Just look at the current dose rates per form of FIP that I'm about to present to you and say, okay, this cat had neurologic FIP, this is the dose rate I'm going to transfer them onto. And you can literally just stop the unlicensed one day and start the compounded formulation the next day. Don't try and convert what the cat has been getting on unlicensed formulations into what the equivalent might be of a compounded formulation, because it's an impossible equation. So in terms of the current recommendations for treatment using remdesivir and GS, I guess this is sort of where the general consensus is still lying around treatment dose and duration. So the sort of standard would still probably be 84 days of treatment is still being recommended. You can utilize either remdesivir or GS 441524 at the same dose rate. And really for me as a clinician, the main thing I'm trying to establish with these cats at the time of commencing therapy is whether or not there is ophthalmic or neurologic involvement. I treat effusive and non-effusive cats that do not have ophthalmic or neurologic involvement the same. They get 15 mg per kg per day of either remdesivir or GS. For really advanced state cats where they're essentially moribund and unable to really sort of eat on their own or don't have a competent swallow reflex, I'm definitely going to be utilizing parenteral, and I'll use remdesivir pretty much exclusively IV these days. As soon as they're well enough to no longer require IV administration, I start them on GS tablets. I just find subcutaneous remdesivir stings too much, and I have no reason to force my animal to experience discomfort given how confident I am in the performance of oral GS. If there is ophthalmic or neurologic involvement at the point of diagnosis, I utilize 20 mg per kg per day. And I think it's really important as clinicians to make sure you are doing a really thorough ophthalmic and neurologic examination on these cats. Obviously, it is hard when they are really obtunded. And to be honest, I would be assuming that's neurologic till proven otherwise. Those advanced cats, I give them 20 mg per kg. But I have had some very subtle neurologic signs, like a very mild proprioceptive deficit in one back leg, or, you know, a mild anisocoria, or, you know, there can be really subtle signs. So be quite thorough on your ophthalmic and neurologic examinations. If you are utilizing IV remdesivir, we still recommend giving that quite slowly over sort of 20 to 30 minutes at least. But in some instances, people are more routinely doing 30 minutes to 2 hours. Certainly, if you're using the human licensed product Veklury, it is a different concentration. It has quite specific manufacturing guidelines to pre-dilute it and then administer it slowly. You just need to be careful if you are utilizing Veklury in that way, that you're calculating the total volume you're going to administer to your cat. Generally, I make it up to the most concentrated formulation that the manufacturers recommend, because otherwise you risk fluid overload with patients that are the size of our cats. With the remdesivir from Bova, I'm pretty happy doing that as a CRI over 20 to 30 minutes, but you can extend it out to 2 hours if you need to. The main reason for the extended CRI is in human literature, there is sometimes reported anaphylaxis as a side effect of administering it too quickly. With orally administered GS, the general recommendation is still to administer that fasted, purely from extrapolation from bioavailability studies that we have in other species. We are still lacking first dose bioavailability fasted versus non-fasted in cats specifically. So in general, we sort of withhold food for at least an hour before you plan to administer the tablet, and then wait 30 minutes before you provide a full meal. But I am an advocate for giving them either like a lick of a creamy treat to help wash it down, or a tablespoon of wet food, or a water bolus via syringe, just to ensure that we're getting the dose washed down. There has been a movement, particularly, or mainly out of the UK, just in light of some of the preliminary therapeutic drug monitoring that's been going on out of Edinburgh. We still don't have publications from the group, but I think something that we've seen here in Australia with our PK studies so far, and that the US has seen with some of their PK studies too, is that there is a huge amount of variation to the plasma concentrations that are being achieved in cats when you give them the same dose as each other, but also a huge amount of variation within the individual. If you test them on day 7 versus day 14 versus day 21, you may end up with 3 completely different results. I am still unclear, and certainly from our therapeutic drug monitoring preliminary work that we've done here in Australia, I can't find a link between outcome and the plasma concentration that was being achieved. I have examples of cats that had very low plasma concentrations that were smooth sailing straight through into remission, and examples of cats that had quite high plasma concentrations in comparison that needed dose increases, dose extensions, or repeat courses of treatment. So it's a bit of a watch this space for me in terms of whether this is truly a plasma concentration dependent effect, particularly given that GS441524, as you remember from an earlier slide, is still just the intermediate metabolite, the thing that's actually got the antiviral property that's being incorporated into the viral RNA is the active triphosphate, and we're not actually measuring that, and we have no idea about tissue penetration concentrations of the active triphosphate at this point in time either. So it is still a little bit of an area where we need a lot more data and probably bigger modeling data sets to better assess that. But there is some suggestion, particularly it's something that I'll do if cats are not hitting the sort of timeline that I would expect for them to have resolution of particular clinical signs. The first thing I'll often do is divide the dose. So it's something you can do, but the majority of cats that have been treated to date have received SID dosing, and I do still struggle to inflict on my clients double the amount of administration stress and inflict that on my cats too. So I think particularly if you have cats that are difficult to medicate, I'm still very happy at least starting off on SID treatment. And then if we're not seeing sort of an adequate clinical response, perhaps we do consider dividing dose and administering it BID at that time. I do also want to state that the majority of cats now will receive oral GS tablets or suspensions from day 1 and achieve just as successful remission rates. I actually feel we're probably seeing better remission rates in these cats now, probably due to the fact that we're just using higher doses, and it's much easier to get higher doses into these cats from a financial perspective when we're using the oral formulations, because compared to injection, it's still more expensive with remdesivir. But there has been a big thing that I've received plenty of questions from DVMs, particularly in the US, coming from more social media advice groups that are insisting that you cannot treat neurologic FIP without injections. I disagree. And we certainly have not seen that as our experience. Lots of cats with neurologic forms of FIP have gone into remission. The main barrier to starting treatment is going to be in those cats where they're obtunded or moribund and don't have competent swallow reflexes, and there isn't a legal formulation of parenteral remdesivir available in that country. That's the main sticking point. And I guess for clinicians in that position, this is either where we unfortunately might need to suggest to owners that perhaps they should source unlicensed parenteral formulations for the first few doses and administer that. Or I have heard a few reports now of, particularly in critical care environments, the placement of esophageal feeding tubes as a mechanism to deliver the GS. So you can either get the suspension down a tube or crush up the tablet in a water suspension and put that down the tube as well. So that's something else that we can consider in those cases where we do not have access to parenteral administration. Now, treatment duration. So as I mentioned, most existing publications have utilized 84 days of treatment. There's a very exciting, large prospective collaboration between the University of Munich and the University of Zurich that are now pretty much as standard utilizing 42 days of treatment. And that's off the back of this short treatment of 42 days, this publication that was published earlier this year. Essentially, in this study, they had 20 cats recruited, randomized prospectively into either a 42-day treatment group or an 84-day treatment group. One cat died in each of those groups, and they achieved the same speed of clinical resolution of their clinical parameters and the same long-term survival outcomes. So this is sort of the first study that's been able to prospectively document the successful utilization of a shorter duration of antiviral therapy. I guess the one caveat that I just put around this, just whilst we're waiting to see sort of bigger data sets, which are definitely in the pipeline, but just from my look at how rapidly things have normalized in the blood of cats that have been treated in these studies, and also in the previous study by this group using the mutant formulation of GS, these cats respond so quickly and so beautifully. It's so exciting. You see their globulins, and pretty much everything else is normal within 2 to 4 weeks of starting treatment. And I guess just from my perspective in Australia, the cases that I've treated, I don't feel like I see them hitting such quick response rates with those clinical parameters. And so for me, I guess I do just still have it on my radar that I would want to be seeing those cats still meet my remission criteria before I just blanket stop at the 6-week mark. But I think I'm way more likely now to consider a 6-week treatment duration if my cat has achieved my remission criteria by week 4 of treatment. This original publication was predominantly effusive cats, and I guess again, because they're dependent on the oral formulation, there was some exclusions to really severe presentations. So moribund cats without a competent swallow reflex could not be recruited into this study. So this survival statistic of 95% is probably a little bit biased just by not including really advanced cats, whereas in our publication and in the other sort of retrospective studies, there were cats that were essentially moribund that had the opportunity to have intravenous administration of remdesivir, and some of them didn't make it. So it's still, again, needing to sort of flesh out the overall outcomes in the context of how those studies were designed. But very excitingly, I've just returned from the ISCAID 2024 conference in Vancouver, and there were some incredible abstracts being presented, and quite a few from this collaborative group of Munich and Zurich universities. And one such abstract that was presented by Dr. Andrea Spiri from Zurich was essentially extending this to show that they have now treated 67 additional cats with the 42-day protocol and achieved 91% survival rates. Their blanket using 15 mg per kg SID per Oz of the Bova GS formulation tablets to all cats, regardless of FIP form. So in this study, neurologic cats are getting 15 mg per kg, whereas I guess where I've sat and where I think my UK counterparts have generally sat is we're always generally gone for the 20 mg per kg for our neurologic cats. Again, all of this needs to be sort of fleshed out in the wash with more publications. But essentially they had 59 effusive cats, and some of those effusive cats did have neurologic and ophthalmic involvement, or both. They had 8 non-effusive cats, which again, some of those had neurologic, ophthalmic, or both involvement. I think the closing statement was that individual assessment of each patient before treatment is discontinued is still recommended, and I definitely agree with that. I think we need to make sure these cats definitely seem like they've achieved a clinical cure or a clinical resolution of their presenting signs of FIP before we discontinue treatment. The main exception to that rule would be cats that have had particularly spinal cord presentations of their FIP, where they've had, say, bladder incontinence or proprioceptive ataxic kind of changes. I do feel sometimes those either take much longer to recover, like most spinal cord traumas or injuries, or in some instances, unfortunately, those appear to be a permanent acquisition of dysfunction. So it's something for me with those neurocats, it's more as long as the neurologic deficits have been stable for a considerable period of time, then I'm probably going to treat that as just residual spinal cord trauma rather than active signs of viral disease. So what do the tablets look like for anyone that hasn't utilised compounded formulations? This is the GS tablets from Bova, and this is what Stokes produce in the US, which is essentially the exact same formulation. Stokes have sent their formulation to Bova, which goes through their QC program to ensure that the quality of what's being produced by Stokes exactly matches what's been produced by Bova, which is what all the studies have utilised so far. These are 50 milligram quad-scored tuna-flavoured tablets, and in a number of countries now, Bova do also offer tuna-flavoured oral suspension, which is a 50 mg per mil. I believe that's on the cards for Stokes as well. We still, as I mentioned, give it fasted, but wash it down with some creamy treat or water, and always be rounding up to the nearest quarter tablet so that cats are growing into that dose rate between the time, so into that dose and maintaining greater than their minimum dose rate. So I always want to keep cats above that 15 mg per kg per day. And a lot of these cats will put on a considerable amount of weight, particularly if they're that younger demographic, which is the majority of cats that get FIP. Most cats on average will gain a kilo over the 84 days of treatment. So it's just really important that if you're not seeing that cat back for 2 weeks, that they've got a bit of wriggle room to continue to grow before they're going to dip below 15 mg per kg per day. It's also really important if you're utilising the suspension, that's where I would be weighing these cats weekly and adjusting the dose based on the weight gains, because it's a lot easier to outgrow the oral suspension dose because you can titrate that much more accurately. So things that I avoid with remdesivir and GS 441524, as I've just recommended, we always want cats to stay above that 15 mg per kg per day, so always be estimating up. Do not adjust the dose down with weight drops. That's been how we've managed the cats here in Australia. Essentially, with our effusive cohort of cats, it's very common that as they resorb that effusion in that first sort of 1 to 2 weeks of treatment, there'll be a weight drop because they're peeing out that extracellular fluid or that extra third space fluid. And so I keep them on the same dose and then just wait for them to start regaining healthy body weight before I start increasing the amount that I'm administering. Caution stopping before 12 weeks, as I've discussed with the shorter duration treatment. There is an emerging body of evidence to support that, particularly with less severe cases, it's very likely that we'll be able to reduce treatment duration to more like that 6-week mark if they're meeting our remission criteria. And for me, I think where I'm sitting at the moment is that I still would want to be treating for 2 weeks beyond resolution of all referable signs to FIP. Then avoid protracted corticosteroids without good reason beyond the first 2 weeks. And the main caveats to that would be that cats that have IMHA as part of their FIP presentation are likely to need protracted corticosteroids to beat the IMHA into submission. And we do have a cohort of cats that have still successfully achieved clinical resolution. A colleague, Dr. Petra Cherner, who's going to be joining us for the Q&A from this webinar, does have a cohort of cats. We've all sort of been flicking her our IMHA cases to put together a case series to document that. The other caveat to that would be our severe neurologic cats. So if you've got cats that from a neurologic standpoint, intracranial sort of standpoint, would benefit from corticosteroids, definitely don't shy away from utilizing that in those cases. And encouragingly, we had a really nice poster presentation that was presented at ECVIM this year, again from the Zurich University and Munich collaboration. Essentially, the use of prednisolone, even at immunosuppressive doses, did not hinder rapid improvement and may benefit cats with severe FIP-associated neurologic manifestations. But I guess we're coming from a place where historically, when we had nothing better in our artillery for this disease, a lot of people have utilized corticosteroids just as more a palliative step to try and dampen down the clinical signs that are referable to that heightened inflammation. It's not standard. You shouldn't need corticosteroids for sort of more garden variety FIP presentations If they've still got things like uveitis symptoms that are still requiring topical corticosteroids or oral corticosteroids, in our experience, that cat is not on an adequate dose of GS, or it needs to be switched to a different antiviral. So don't think that it's normal that you should still need to be throwing corticosteroids at these cats to control those sort of FIP referable signs beyond 2 weeks if they're on effective antiviral therapy. Minimum monitoring time points. So again, physical examination every 2 weeks if they're on the tablets, and sort of be adjusting dose as needed for weight gains, or weekly weight checks at home, ideally on digital scales. Get your clients to purchase some digital scales, which you can get very cheaply now. I think focusing on clinical response is still really important in the first 2 to 4 weeks of treatment. Historically, with this slide, I've said, and where I've been at for the last probably 18 months, is that I don't tend to do blood tests on my cats until 6 weeks when I'm treating them for 84 days. But now we have this suggestion that we might be able to get away with shorter duration treatment. I would definitely want to look to make sure things are normal before I discontinue that drug. And as I mentioned, where I'm generally sitting with the evidence at the moment is that I would want things to be normal for 2 weeks before I discontinue the antiviral. So I would reintroduce a blood test at that 1 month mark. So CBC and biochem are definitely mandatory. If you have access to AGP and serum amyloid A, they can be helpful. AGP from some study groups is showing to be an important marker or indicator for success of remission. So if you've got access to acute phase proteins, definitely incorporate that. If you are treating for that 84-day duration, I'd be rechecking sort of monthly before discontinuing the drug. If you do need to do dose increases, I tend to recheck things every 1 to 2 weeks after adjusting the dose to make sure we've seen an adequate response. And if you do need to do dose extensions, then I'm generally looking at things every 2 weeks until remission is achieved. Now, this slide is something that was essentially an extrapolation from our prospective in Australia, where we were using the 84 days of treatment. And the 50% of this cohort were receiving much lower dose rates, essentially almost half the current standard dose rate for their FIP. And so I very much consider these the absolute latest I will accept for resolution to still be classified as an ideal response to FIP treatment. But essentially, if we're seeing sort of cats missing these milestones, that should be an indicator to consider a dose increase or the addition of an extra antiviral or a switch to a different antiviral. But I think my general rule of thumb is go harder sooner rather than just kind of waiting and then ending up needing to extend treatment, just because that's going to continue to increase the expense to your owner and the stress on your animal for duration of treatment. But this is essentially one of those cats that was recruited during the lower dose rates, where we were still figuring things out and learning what was effective. And he kept having breakthrough episodes of uveitis with a hyperglobulinemia and ended up on a very long treatment course. With regards to adverse drug reactions with remdesivir and GS, it's very minimal, particularly now that we're using oral formulations. There's definitely been some consistency for a potential for ALT elevations, but I do still think the jury's out on how much of that is a disease effect versus a drug effect. There's a lot of the earlier studies, including ours, that documented the development of eosinophilia. And again, there's always been a question mark around disease versus drug effect. Another fabulous abstract that was presented, or sort of talk that was presented at this ISCED 2024 conference, was from the Munich group discussing that short and long-term treatment duration study. And interestingly, the eosinophilia was only observed in the cats that received protracted courses of the drug and then resolved after discontinuation of the drug. So there is maybe a little bit more of a suggestion that the eosinophilia might actually be a drug reaction rather than necessarily an immune response. From the COVID human literature, the development of eosinophilia was actually potentially a positive prognostic indicator of a favorable immune response. And so I think, again, there's still more work that needs to be done to better elucidate that, but there's a little bit more of a chance that perhaps we are seeing a drug reaction. By far the main adverse side effect that we've seen with the use of remdesivir or parenteral GS through unlicensed formulations has been the injection site discomfort and potential for skin irritation. With the Bova formulation, the skin irritation side of things is pretty mild in general. The injection site discomfort can range from non-existent to really severe, and the cat's needing to receive buprenorphine and gabapentin and topical local anesthetic preparations to try and reduce the discomfort. And that's, again, why that's been completely eliminated. Now we can just transition these cats onto oral GS tablets. But with the unlicensed formulations, I think the local skin irritation can be a lot more severe. These are really acidic preparations, and there's been sloughing and all sorts of horrible things reported. So I'm going to switch to molnupiravir and EIDD1931 now. And I guess I just want to start by saying, just because they're kind of the same, they're really not directly comparable to remdesivir and GS. With remdesivir and GS, so remdesivir at least has been utilized extensively in human medicine through the COVID-19 pandemic. And from the rat and mouse and rabbit studies that were performed, particularly around reproductive safety, there hasn't been any signs of mutagenesis or teratogenicity with these drugs. Remdesivir has been utilized in pregnant humans without evidence to support an increased outcome of birth defects or adverse events during pregnancy. And that's not the case for molnupiravir. So the human safety recommendations around molnupiravir, which again is also being utilized extensively for human treatment for COVID-19, but those rodent studies did find mutagenic and teratogenic side effects. It is not recommended in humans that are under 18 years of age. It is not recommended in humans that are pregnant. And I think the general recommendation needs to be that staff should be wearing gloves and owners should be wearing gloves to administer these drugs. There's also been sort of more of a suggestion in the human literature that following the introduction of molnupiravir, there has been direct mutational signatures that suggest the virus has adapted to the introduction of that antiviral. So there's more suggestion that resistance may start to manifest with sort of broader use. And so, again, these are drugs that I firmly believe should be reserved as a second-line antiviral. The main issue with that is that in a lot of areas of the globe, molnupiravir can be accessed incredibly cheaply, whereas GS and remdesivir are still incredibly expensive. If you have an owner that has the financial capacity to treat with GS, that is absolutely still my preferred drug. I think it's safer. I do think it's better from the preliminary data that we've got and from my anecdotal use of both of these drugs. And I just think that from an antimicrobial stewardship perspective, it makes sense for us to try and create, like we do with antibiotics, first-line antivirals, and if they fail that, then we reserve these other drugs that maybe have narrower safety margins as our backup plans. But I still don't want cats to die of FIP. So if the only thing your owner can afford and that you can legally access is molnupiravir, there's an increasing amount of literature supporting that this is still another very effective antiviral. So with regards to the use of molnupiravir after failure to GS, we had this publication from Roy et al., which is utilizing unlicensed formulations. They achieved survival of 92% with owner-reported data. We then had a prospective observational study out of Japan of 18 cats with molnupiravir that achieved 77% survival. There was then most recently a non-inferiority study out of Davis that compared molnupiravir to GS 441524, and the molnupiravir group achieved 80% survival. These two studies were were cats that were receiving this as a first-line antiviral that achieved these survival rates. Just one thing that I want to put out there, though, particularly with something like a non-inferiority study, the numbers in this are low, and that's the benefit of a non-inferiority study. Essentially, non-inferiority is about comparing to the current standard treatment, which is GS 441524. In this very small study where they had 9 cats that had historically been treated with GS, only 5 of them survived. So it's a survival rate of 55%, whereas 10 cats that were now treated with molnupiravir, they had 8 survive, which is 80%. It's very tempting. The clinician in us, I think, finds it very tempting to go, well, 80% is better than 55%. I'm going to use molnupiravir. But these studies are not powered for superiority. When we're looking at drugs that are most likely both effective greater than 70% of the time, the number of cats we would need in each of those groups to truly assess whether something like molnupiravir is superior to GS would be thousands of cats in each study. So I think from all of these comparative studies, the take-home message is that molnupiravir is unlikely to be significantly worse than GS 441524. There's another prospective study underway by my previously mentioned colleague, Petra Cherner at CSU. She's treated 62 cats, all prospectively recruited with molnupiravir, and they achieved a 66% survival with no relapse. 11 of them relapsed but responded to higher courses of treatment, and 23% of them died or were euthanized. So the overall survival statistic was 77% there. With treatment, again, in Australia with molnupiravir, we have this observational study in submission at the moment that the wonderful Tessa Clark has put together. This was a combination of cats that had either had first-line molnupiravir, which achieved 72% remission, or cats that had a short course of remdesivir or GS and then transitioned across to molnupiravir. They achieved 86%, or cats that had already failed GS or remdesivir treatment. That was only 7 cats, but they had 100% survival. So how do you use molnupiravir? These are, I guess, the preliminary suggested use dose rates that are extrapolated from the existing publications that we have. The main difference between GS and molnupiravir and EIDD 1931 is we always give these drugs BID. Wear gloves because of the potential mutagenic and teratogenic side effects. Most of the time, these are human capsules that need to be subdivided if you're utilizing things like IndiaMart or other off-label prescriptions for human formulations of this drug. They require manual subdivision. However, one of the compounders in the US is now compounding molnupiravir, so that would be a dose appropriate for the animal. It does, extrapolating from other species bioavailability data, you shouldn't need to fast animals when you give this, and we have just mixed it into a creamy treat and they lick it up. It doesn't seem to have a problem with palatability, but it is a narrower safety margin. So adverse effects include leukopenia, which is probably the most common thing we've seen in Australia with utilisation of molnupiravir and EIDD 1931. Folded ear tips, brittle whiskers, flaky skin, nausea, vomiting, anorexia, muscle wastage. The Japan study had ALT elevations and jaundice to the point of requiring hospitalization for 3 days. So more, I guess, adverse side effects, particularly at higher dose rates. Although talking to Petra in her CSU cohort of cats, she didn't see the same level of adverse side effects, which is encouraging. The wonderful Dr. Alex Kennedy, based out of SASH in Sydney, did a prospective using EIDD 1931 from Bova, supplied by Bova AU. And the dose range that she used was 15 to 20 mg per kg BID. All 9 cats are still alive, but similar set of adverse side effects, the neutropenia, ALT elevations, decreased appetite, and brittle whiskers. We then had another study out of the Japan group that prospectively recruited 118 cats. They all received 84 days of treatment. Owners elected whether they would get GS, which was the mutant, the unlicensed formulation, or whether they would get molnupiravir. So this was non-randomized, but they had 59 in each cohort. They achieved 80% survival with GS, and they achieved 86% survival with molnupiravir. So again, it's unlikely that molnupiravir is significantly worse than GS. Again, this is not powered for superiority. And the cat's biochemistry normalized at the same rate between both of those cohorts, which is also good. So I'm just going to really quickly touch on protease inhibitors because I think that these are the next frontier for combination antiviral therapy. So essentially the very first publications that we had in this space were actually using the protease inhibitor GC376. And this is a different mechanism of action. This is inhibiting a highly conserved enzyme that's responsible for viral replication rather than actually disrupting the viral RNA with insertions or deletions. So they achieved, so 6 out of 8 cats had complete reversal with experimentally induced FIP, and then 7 out of 20 client-owned cats survived, which is obviously a lot lower than GS and molnupiravir and the nucleotide analogs that we're now utilizing, which is why continued investigation into using these as first-line antivirals or as monotherapy has essentially stopped. But when we look at combination antiviral therapy, it makes a lot of sense to, in my opinion, to be utilizing 2 different antivirals with different mechanisms of action to try and improve and reduce treatment duration. And this is one study that did such. Essentially, this is out of China. It utilized subcutaneous formulations of both drugs. There were 46 cats that had 4 weeks of treatment. 2 did require dose extensions of the GS, but they achieved 97.8% survival. And another colleague of mine, Dr. Sam Evans, who a group at CSU have done a lot of work with the unlicensed formulations. They're kicking off a prospective looking at oral GS and oral GC376 as a combination antiviral therapy, which will be really exciting to watch that space. Then Paxlovid, which is something that we have more utilization to because this is a Pfizer drug that was developed for COVID-19. Sorry, just to backtrack. GC376, the patent to that belongs to a company called Anavive Life Sciences. They are in the process of registering this for veterinary use with the FDA, but it's been a few years of silence on that front. So in the meantime, something that we have started utilizing for refractory cases has been this Paxlovid, which is actually 2 different pills in the box. Nematrelvir, which is the protease inhibitor, and then ritonavir, which is a PK booster, because nematrelvir is really rapidly metabolized. There are 13 cats now that have failed GS or failed to achieve remission on GS or molnupiravir alone that we've added this into, and all of them so far have turned a corner without any notable overt adverse side effects. The preliminary dosage that we've been utilizing is half an nematrelvir and a quarter of the ritonavir BID. Although in little cats or potentially even in all cats, we may eventually get away with giving less. I know UC Davis are doing some prospective work investigating that. But it is available off-label. I can write a script for that here in Australia. US can write scripts for this too. So if you're in another corner of the world, just investigate whether or not that's something that you might be able to utilize off-label for these refractory cases. So frequently asked questions. I'm actually going to skip through this. This was a slide that kind of I actually meant to delete, if I'm honest, because I just want to run through things in a little bit more detail. Ultimately, a couple of things that I want to sort of just touch on is whether a treatment trial is a diagnostic option. It is. And I've said for a long time that just go ahead and start these cats on treatment, but I am starting to backtrack a little bit because my inbox right now is just full of cases that never achieved a confirmatory diagnosis of FIP. Everyone jumped the gun, just started them on antivirals, and now we're chasing our tails as to whether this is a true poor responder or whether or not this cat never had FIP to begin with. So yes, it is in those really, really, really obvious, like effusive cats that are dying in front of you, absolutely get them started on treatment. But for those cats that are still smoldering along and you're kind of not sure, make sure you do as much diagnostic work as you can to rule out other pathology as well as testing for FIP. Do FIP effusions always have high protein and low cell count? This was another wonderful abstract that was presented out of the University of Zurich, prospective work. Essentially, they had 100 cases of effusive FIP, and 58% of them were classified as exudates. And this is something that I've seen in our lab in Sydney, and I've been meaning to do this publication because I do think a lot of these cats don't fit the mold of having that classic straw high protein effusion. I've seen chylothorax as a co-presentation in these effusions. We've seen exudates. So just because it doesn't look like strawy sticky fluid doesn't mean it's not FIP. Can you vaccinate and neuter? Yes, you can. So this was from the retrospective study. These cats were all received vaccinations and neutering without evidence of relapse. In general, I try and wait kind of 2 to 3 months after they've finished treatment. Can you chop and change antivirals? You absolutely can. I'll start them on remdesivir or GS, and if my owner can't afford continued treatment, I'll switch them to molnupiravir. Can you taper the dose? No, you cannot. Do not go, okay, well, this cat's responding well and I need to conserve money to stretch out the treatment period. Go hard for as long as your owner can afford. Don't start cutting the dose. And should you still treat if these are retroviral positive? My answer has been yes for some time, and we had some preliminary emerging evidence from Sam Evans's group, so showing a favourable response to treatment in retroviral positive cats that had undergone treatment with unlicensed formulations. But again, we had a really lovely abstract presented at ISCAID from Emma Levine from the University of Florida. This was working with a shelter with a very high FELV population of cats. And essentially, the FELV group achieved the same survival rate through the treatment and observation period to 6 months as the non-FELV group. They then, in terms of long-term mortality, FELV group did kind of succumb to essentially the normal timeline that you would expect for an FELV positive cat to survive. So there's still no reason to deny these cats of treatment. If owners can afford treatment, their quality of life is going to be considerably better. And should you be treating enteric coronavirus as a prevention for FIP? My firm recommendation is you should not be doing this. This is the ubiquitous virus. This is the best way we're going to end up with widespread antiviral resistance. So please don't be advocating for blanket treating entire shelter populations or breeding colonies with non-symptomatic cats for enteric coronavirus. I'm going to run out of time, but in summary, remdesivir and oral GS, in my opinion and the opinion of many other people working in this space, should be our first-line antivirals. Switch to molnupiravir or EIDD1931 if you're seeing a poor response or if it's entirely cost-prohibitive to use first-line antivirals, and consider adding in a protease inhibitor for refractory courses of treatment, and maybe that might help to reduce duration of treatment as well. But this is going to continue to evolve rapidly. Things are literally being published weekly, which is why with the assistance of ISCAID, I'm part of a committee that's been formed to develop treatment guidelines for FIP using the GRADE methodology of guideline development. And this is sort of, I guess, involving stakeholders that are affected by FIP. So the group of us cover specialist veterinarians, general practitioners, virologists, clinical pathologists, breeders and owners, and we span many different parts of the globe. There's representation from Australia, Asia, North America, South America, Europe, UK. So that'll be an exciting thing to watch this space. All right, that ends my talk. Thank you very much.